My name's Craig McDonald from the University of California, Davis in Sacramento, California. I apologize I couldn't be there with you all due to an illness, but I'm actually excited to share with you some new analyses that we have recently been conducting that looks at definitions of clinically meaningful disease progression in terms of motor function decline in Duchenne muscular dystrophy, and specifically the evaluation of time to event endpoints and how they could be used in clinical trials, and also some preliminary data with regard to some prognostic modeling using some very straightforward clinical assessments. This work has been conducted with colleagues from the CTAP Collaborative Trajectory Analysis Project Group, Doctors Montoni, Martin, and others, including Susan Ward, Natalie Gomez, and James Signorovich. How do we determine efficacy of a drug in a clinical trial? Oftentimes, the most common approach is to assess the difference between the effect on a clinical endpoint, comparing drug-treated patients with placebo-treated patients over a specified period of time. So if a particular endpoint, for instance, is using the North Star Ambulatory Assessment, what has been historically done is to compare the change in the North Star at the end of the trial versus the North Star exam at baseline. And there you see data on the right from the recent Pfizer donidalorsen study of a myostatin inhibitor. This actually showed a trend favoring the treated group, but again, it was not statistically significant at 1 year at the 1 year outcome time point. So this has been the approach used in most Duchenne clinical trials. It can be confounded if the two groups are not similar at baseline, and variance can be a problem from a statistical point of view as well. What about time to event analyses, or using really hard time to event analyses such as survival? This is usually done for cancer clinical trials. These hard endpoints are favored by regulators. They're less subject to mood of the patient or behavior, motivation, fatigue, and oftentimes have less subjectivity. So for instance, in cancer trials, survival is often used as an endpoint, for instance, survival at 5 years and so forth. For Duchenne trials, depending on what event is chosen, there need to be enough events that need to occur during the trial to detect differences between the drug and placebo-treated groups. So loss of ambulation, for instance, was chosen as a hard endpoint. Frequently, there's not enough loss of ambulation that occurs in the course of a 1 year clinical trial to be used as a time to event analysis. But some of these time to event analyses have frequently been used in a registry context, and the data in the lower right is actually from the STRIDE registry showing data on loss of ambulation in Adalurin treated patients shown in the red versus a natural history comparator group from the Synergy natural history data set. And you can see the prolongation in ambulatory ability and function in the Adalurin treated patients in the context of this long-term registry, where patients were followed for periods of up to 4 to 5 years. So what we were asking, is it possible to create a time to event endpoint for clinical trials using perhaps the North Star ambulatory assessment tool, and really looking at the activities and abilities assessed by the North Star in a time to event manner? And what we ask is how much change in the North Star is clinically meaningful. Can the definition we derive be used as an event? In a typical trial, how many placebo patients would experience a clinically meaningful change over the course of the trial? And can we use this time to event to actually predict a downstream clinical milestone such as loss of ambulation? And importantly, can we detect a difference in events between a drug-treated group and a placebo-treated group? I want to give you the concept, statistical concept of the minimal detectable change on an endpoint. This is an important concept. It's the minimal magnitude of a measured change, which is indicative of a true change due to acquisition or loss of motor function related to the disease or the treatment of the disease, rather than to just day-to-day variability or transient variation or measurement error that might occur from day to day. And so we can measure actually the variation around patient-specific fitted trajectories of their endpoints over time. And using statistical techniques, we can actually derive estimates of the minimal detectable change and thresholds that provide greater than 80% confidence that the observed changes reflect an underlying true functional change and not just due to day-to-day wobble or day-to-day variation in the measure that might occur from day to day. And with the North Star, the estimated thresholds for greater than 80% confidence of a true change have been estimated recently to be 2.8 points on the North Star. So here over on the right, you can see the standard error of measurement approach to derive the minimal detectable change. And here you can see the individual's fitted curve and the deviations day to day from that individual's fitted curve that represent measurement errors and or transient temporary biological variation, but not true disease progression. So that's the concept of the minimal detectable change. I also want to note using fairly straightforward clinical assessments, such as time to stand from supine, we can actually derive important prognostic information. These are 4 different trajectory populations with Duchenne dystrophy. The red trajectory is the most rapidly progressive or severely affected population. The green curve would be more mildly affected patients. But what you can see from all 4 of these trajectory groups is that patients that have a rise from floor time, a rise from supine time of greater than 5 seconds, all of those trajectories are going upward in a very precipitous, aggressive manner. Whereas below 5 seconds, patients are either improving due to maturation over time, they're either stable, or they're perhaps rising at a much slower rate of disease progression. So the 5-second rise from supine time has been used as a prognostic indicator in Duchenne dystrophy. Similarly, if we time patients on a simple 10-meter walk-run time, this is data from the PRO-DMD natural history study showing the proportion of patients that lose ambulation once their 10-meter walk-run time exceeds 10 seconds. And what's really striking in this data is that virtually 100% of the patients will lose ambulation within the next 2 years once their 10-meter walk-run time has exceeded 10 seconds. So this now becomes a more proximal hard endpoint. We refer to it as approaching loss of ambulation, a 10-meter walk-run time exceeding 10 seconds. So this would actually be predictive of loss of ambulation within the next 2 years. So this approaching loss of ambulation is becoming an important milestone. We're also looking at the losses of different items on the North Star as indicators of clinically meaningful disease progression. The loss of 2 different North Star items, so not the loss, for instance, of a bilateral item, such as the loss of right hopping and left hopping, but the loss of 2 distinct items on the North Star is also an indicator of clinically meaningful disease progression. This is consistent with the North Star construct across the 17 items, across the severity of the ambulatory spectrum. It's consistent with the ration analyses of the North Star, which sequentially orders the items from those that are more difficult to perform and are lost earlier in the course of the disease to those that are lost later in the course of the disease. And this is more inherently meaningful than a given change on the linear North Star, which weights the items, each individual item differently. So for instance, here's the North Star items, the 17 items, from those that are most difficult, lost early in the course of the disease, to those that are lost later in the course of the disease that are less difficult. And again, you can see that oftentimes the bilateral items are lost at the same time. So the concept here is actually the loss of two distinct items. So the loss of hopping ability and stand on heels, for instance, or the loss of rise from floor and running ability. So this shows schematically the concept of losing two different items on the North Star, which is a measure of clinically meaningful disease progression over time in a Duchenne patient. So the construct here that we're looking at is in a decline group population. So those that are standing from supine in greater than 5 seconds, perhaps a 3-point decline in the North Star would be predictive of more rapid loss of two different items on the North Star. Loss of two different items on the North Star would predict subsequent approaching loss of ambulation or a 10-second, 10-meter time. That milestone would be predictive of loss of ambulation, which is predictive subsequently of loss of overhead reach and loss of hand-to-mouth function. Similarly, for a stable group, those with stand from supine times less than 5 seconds, we might look at whether a patient population gains 2 or 3 points in North Star, an increase in North Star, versus those that don't increase on the North Star. And perhaps that might be indicative of subsequent transition to a 5-second stand from supine time, a transition to loss of stand from supine ability, and subsequently loss of approaching LOA or a 10-second, 10-meter time. So what we've done in the CTAP data set is we've looked at a large population of patients, those in the decline group, ages 6 to 18 years of age, with rise from floor times greater than 5 seconds, and a stable group, those that are 4 to 8 years of age with rise from floor times less than 5 seconds. And we've ultimately looked at those with a number of longitudinal assessments, 619 in the decline group, 360 in the stable group. And if we look at the decline group, here is data on time to loss of 3 points on the NSAA for those in this decline group with greater than 5-second rise from floor times. And the median time to loss of 3 points is actually less than 1 year, 0.92 years. So the majority of patients, at least 50% of the patients, actually lose 3 points on the North Star in less than 1 year time, which would be a typical time frame for a clinical trial. We also looked at the inherent noise in this in terms of how many will actually revert once they've lost 3 points on the North Star, how many will actually regain function on the North Star subsequently. And so this data actually shows that once you get past 12 months, the loss of 3 points on the North Star from baseline does not spontaneously recover or revert to the baseline values. So this actually represents true disease progression if it's occurred by 12 months after the onset of a clinical trial. Similarly, we can look at the time to loss of two different items on the North Star. This occurs subsequently or later. The median time to loss of two different items on the North Star is a little greater than 1 year, 1.17 years. And if we look actually at the predictive value of loss of two different North Star items and how that relates to future loss of ambulation, if we look at patients that have lost two different items versus those that have not lost two different items, there's actually a 6.5-fold increased risk of loss of ambulation in the data shown on the right in those that have lost two different items versus those that have not lost two different items. So this is highly predictive of future loss of ambulation in Duchenne patients. Similarly, the loss of two different North Star items predicts risk of progressing to future approaching loss of ambulation milestone, the 10-second, 10-meter time. So there's a 2.8-fold increased risk of progressing to this approaching loss of ambulation milestone. And also the loss of two different North Star items predicts risk of future loss of overhead reach by greater than two-fold with the data here shown on the right. What about the stable patients, those that are actually less than 5 seconds? These have been patients that have frequently been enrolled in gene therapy trials, for instance. If you look at their median time to loss of two different items, it's actually 3.63 years. So it actually takes them quite a long time to lose two different items on the North Star, those with those more stable rise times. They eventually will lose two different items, but it just takes them a longer period of time in this stable population. So again, the time to event, 3-point change of the North Star gives insight into clinically meaningful disease progression, and potentially it could be incorporated into trial design to minimize placebo exposure. So for instance, once patients in a clinical trial decline 3 points on the North Star, they could be rolled over to the alternate treatment group, as opposed to waiting 18 months of placebo exposure. You could design a trial where once patients decline to a clinically meaningful amount of disease progression, they would roll over from one treatment arm into the next. So for instance, placebo-treated patients would roll over into active treatment. So that's one of the concepts we are exploring potentially with sponsors as well. And I want to end by just also indicating the use of composite prognostic scoring for time to loss of ambulation using very straightforward clinical endpoints, which is showing some real value in terms of prediction of loss of ambulation. So this is all work in progress with the CTAP group. We have actually come up with a simplified risk scorecard for predicting time to loss of ambulation using really just two very straightforward clinical assessments, rise from supine or rise from floor time, and the 10-meter walk run time. These are all, this is data from steroid-treated Duchenne patients. And using just these two endpoints, this is data on the left from the CTAP group, and we come up with actually 5 risk categories. The most severely progressing group, the risk group on the far left, actually will lose ambulation. 50% of patients will lose ambulation within a year. The second risk category, essentially 50% will lose ambulation within 2 years. In the third risk group, they generally 50% of the patients will lose ambulation within 3 years. The fourth risk category will lose ambulation over 4 years, and then the more mildly progressing patients will eventually begin losing ambulation around year 5. And we have actually taken a large data set from the CTAP, developed this prognostic modeling, and we've actually validated this with a completely independent natural history group, the Synergy Natural History Group data shown on the right, which really shows very nice validation of this prognostic scoring for loss of ambulation. So we're excited about this and how it could be used for clinical trials. Just to show you here, these are data in a natural history cohort. Actually, the solid lines are showing loss of ambulation in one standard of care steroid-treated group with deflazacort. The dotted lines actually show the loss of ambulation in prednisone-treated patients. Very consistently across all 5 risk categories, you can see some advantages of the one steroid regimen versus the other. We believe that this type of approach could be incorporated into perhaps even registry analyses for long-term follow-up of patients that are treated with a novel Duchenne therapeutic versus those that receive standard of care treatment. So again, the prognostic risk assessment for loss of ambulation, this could potentially be used in trial design. It could be used for inclusion criteria in clinical trials. It could be used for stratification purposes across treatment groups. And also it could be used for phase 4 registry long-term follow-up using very simple endpoints, which are collected day-to-day in our clinics, in our Duchenne clinics. And also these risk assessments could also be used by clinicians to provide helpful prognostic information to families. I'd like to just acknowledge my CTAP colleagues on these projects. And we have, I think, a few minutes for questions. Thank you very much.
Thank you, Craig, and thanks for joining us by video. We wish you were here. We miss you and hope you're feeling better and staying, at least getting on the side of health as opposed to feeling pretty horrible. So thank you again. Does anyone have any questions? I have lots of questions for Craig. I always do. All right, so Craig, I'm going to ask you the first question. And so this is probably complicated. I'm going to have more questions as it kind of flows out of my head. So I think in clinical trials, one of the most frightening things about a phase 3 or other trial that includes a placebo, I mean, I think this community is used to a 12-month placebo, but when we get into 18-month placebos, that feels horrible and risky. And we've always talked about rescue protocols. What if my child starts declining and then we're all making assumptions of that's the placebo, right? We all make those assumptions. So do you think that this will do several things? One is maybe decrease that 18-month period for a clinical trial to understand what's happening? And will it be able to better inform who needs to get on active product, or better make more companies more comfortable of breaking the blind so they see if this child that's declining is on a placebo? That was a lot, sorry.
That's a great question, Pat. And again, I would love to be there with you all. I am feeling better. But your point really pertains to this issue of prolonged placebo exposure. And I think the potential for these event-driven trial designs would really be to better scale the duration of placebo exposure to just that which is needed to confirm or rule out drug efficacy. So if a drug is highly effective, the trial could actually, potentially end early, so that all patients wouldn't have to necessarily have a full 18-month or even longer placebo exposure. If a drug is less effective but still promising, the trial could run a bit longer. If the drug doesn't work, the trial could stop early. So I think this idea that if a patient reaches a failure criteria, once a certain duration is met, that they could roll over to active treatment once they've at least perhaps reached the decline criteria. I think that would have inherent desirability and benefit, certainly to the patient population and the patient community. But it is an approach we're considering to incorporate into future Duchenne platform trials. And I think this could also be done with upper limb endpoints, using other endpoints such as the performance of upper limb as well.
Thanks, Craig. So you're talking to companies. Are they enthusiastic about this? Just from a pediatric point of view, to make little boys who are distractible go through 17 different measures, if you could decrease the number of measures and still have the same statistical predictability, is that where you're hoping to go?
Yeah, I think certainly the sponsors are open. We've also looked at potential of short versions of the North Star, where perhaps we wouldn't have to necessarily administer all 17 items. That's promising work as well, and certainly one that could be incorporated into some of the registry follow-ups as well. I did want to also make a comment. In terms of these endpoints, I think even the forced stair climb, Michael had mentioned that I wasn't a real fan. I would say I had some healthy skepticism, but I'll say that recently Tau Pharmaco, with their Javinostat trial, has actually used the forced stair climb as a primary endpoint, and they actually used MRI findings at baseline to develop a non-target population for their pre-specified primary analysis. And I think you'll hear some of those trial results presented this week at PPMD. So I think there's still we're learning a lot about these endpoints, the North Star in particular. other endpoints such as the four-stair climb. I think it's going to help out considerably moving forward here in the near future.
So Craig, just, we've concentrated here in your talk. So I have a question. If you can imagine, crazy as I am, if my two boys here were here today, I'd probably be testing them on the supine to standing as well as 10-meter walk run every single day to predict in my head what's going to happen in the long run, because I was always about 10 years ahead of what today really was for them, and always very worried and wanting to have that information. So would you recommend that people are doing these two measures at home and making predictions in their own mind and heart?
No, absolutely not. I think this is something that really should be done at a Duchenne Care Center, by the physicians and clinical evaluators. And I think the interpretation, needs to be sort of discussed with your clinicians. I think this is still something that we are looking at for, clinical trial design purposes as stratification measures and so forth. But there's still a lot of variability in patient outcomes, and I think it's important for I think families not to focus too much on these particular time function tests.
Thank you, Craig. So talk to us about the PUL 2.0. How are we, because when our young men have lost ambulation and some of our young women who are demonstrating weakness, and we're trying to measure their upper body, what kind of measures in addition to, or how sensitive do you feel PUL 2.0 is? What does it measure? How do you think we can use it in trials?
Yeah, that's a really exciting advance in that previously a lot of the non-ambulatory trials actually incorporated pulmonary function testing as primary endpoints. We've learned that really trials need to be really quite large and huge trials to actually make use of pulmonary function as a primary endpoint. And I think even the regulatory authorities, particularly the EMA, questioned the clinical meaningfulness of, say, a 5% treatment effect on a forced vital capacity. But the performance of upper limb has really performed in a phenomenal manner in recent non-ambulatory Duchenne trials. The FDA, particular CBER, which is the regulatory branch of the FDA that focuses on gene therapy trials, they actually like the PUL 2.0 version. It's been really well put together. It's a 3-point scale, very similar in construct to the North Star 3-point scale, and the FDA was really quite pleased with that. And I think as we've learned from some recent clinical trials, you don't have to have huge clinical trials performed for long periods of time to be able to show a statistically significant effect using the PUL 2.0. And I think you'll see some data presented later this week from Capricor, even in an open label extension context, showing sort of the value of the performance of upper limb in the non-ambulatory population. The other point that I should mention is that we can actually start to employ the performance of upper limb in a late ambulatory population. And so many of the trials are now including patients that are in that late ambulatory stage with 10-meter walk run times of, say, greater than 10 seconds. And those patients are actually, showing, some change in the performance of upper limb. So those patients can actually be included in the same trials that we are previously we're just focusing on non-ambulatory trials. So we now are actually including this transitional population that were oftentimes really in the back of the bus and were never included in clinical trials. But now we actually have trial designs that allow both a late ambulatory population as well as a non-ambulatory population to be included in clinical trials, which I think is a really exciting development.
Yeah, thanks, Craig, because, in gene therapy trials and some of the other trials are using that 4 to 8 or 10 population, and then the non-ambulatory trials are much later population, so it feels like there's that group of young adolescents transitioning to non-ambulation that seem to be, as you said, in the back of the bus. So in the interest of time, I have one last question, and it's probably a ringer, and you can say no. I'm not going to talk about it. But what sometimes we're hearing from people in various trials, antisense oligonucleotides or the gene therapy trials, is, as we know, boys with Duchenne are lordotic in that when they walk, they shift their weight back a little bit from the center of gravity in terms of sticking their belly out. And some of the families have said that is gone or different or straighter. Are you measuring lordosis, and is there a measure that would be statistically interesting or useful to look at lordosis and its changes in studies?
Well, that's a great question. I think some of the novel measures, such as the Duchenne Video Assessment, actually gets at some of those compensations and some of those quality of movements. And those videos are actually scored by expert physiotherapists and clinical evaluators. We also are developing approaches where we actually are placing wearables on the belt. This is either Apple Watch types of wearables that are actually giving us very sophisticated information about the biomechanics of gait and some of the compensations that are being utilized with some of these gait changes. So I think increasingly with some of the wearables, I think we're going to be able to see some of these more subtle changes, as you point out, the lumbar lordosis, the anterior pelvic tilt, the abdominal protrusion, degree of toe walking, Trendelenburg gait, all these biomechanical compensations are, I think, going to be elucidated by some of these newer evaluations that are being validated. And I'm really quite excited about the use of wearables. And those are certainly being employed now in the gene therapy trials. And I think are going to be also included in some of the non-ambulatory trials as well, wearables on the upper limb.
Good, thank you, Craig. Craig, I can't thank you enough for joining us. We wish you were here. If you feel better, please come over here. You're not so far away from Arizona, and we'd love to have you. But thank you so very much for joining us, and we'll count on you next year with no illness at all. So thank you for joining us.
Great, my pleasure, Pat. Thanks.